titled Transplant for Aplastic Anemia and MDS. Thank you for joining us. I'm Lee Clark, Director of Patient Services. As we get started, I'd like to recognize the generous support of our corporate sponsors, Alexion, Apellis, Amogen, BioCrest, Bristol-Myers Squibb, Genentech, Novartis, Regeneron, Servier, and Tahoe Oncology, and the generous support of our patients, families, and caregivers, who this conference would not be possible without your generosity. Immediately following the presentation, there will be a question and answer session. If you're participating online, you can submit your questions at any time in the engagement panel by using the Q&A icon on your right. Just type in your question and hit enter, and we'll get to your questions as well at the end. For those of you participating in person, we will be going around to each location, and the staff in the room will have a microphone, and the microphone will be handed to you. Please wait for the microphone so we can hear the questions being asked, and then we can hear the answer from our expert speakers. When asking questions, I do ask that you do two things to help us manage your incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speakers cannot answer any specific questions related to your personal health care. For this session, we have two experts. We have Drs. Nandita Khera and Dr. Hemant Murthy. Dr. Khera is a consultant, Division of Hematology Oncology, the medical director of Ambulatory Infusion Center Hematology Oncology, and a professor of medicine. She treats patients with blood cancer, especially those needing bone marrow transplant for their disease. Her research focuses on improving the delivery of care to patients with cancer to help them better prepare for the psychosocial and financial consequences of their treatment. Dr. Hemant Murthy is a consultant and associate professor of medicine at the Mayo Clinic in Jacksonville. As a hematologist-oncologist physician, he specializes in bone marrow transplant, CAR-T therapy, and acute leukemias. In addition to his clinical activities, Dr. Murthy is very involved in research and publishes in high-impact journals. AAMDS is also grateful that Dr. Murthy serves as a member of our Patient Advisory Council. With that said, I'd like to welcome Drs. Murthy and Dr. Khera, and we're going to get started with Dr. Murthy first in Jacksonville.
Part of AMDS and Mayo Clinic, and to be able to talk to you all today about bone marrow transplantation. I'm just waiting for a presentation to. Next slide. Okay.
Can you hear me?
Okay. So I will discuss about about allogeneic stem cell transplantation in general, and then we'll move on to discussing transplant specifically for aplastic anemia, and then I will hand it over to Dr. Khera, who will talk about transplant for MDS as well as factors that impacting success and preparation. Next slide. So what is a allogeneic bone marrow transplant? So this is a procedure where the bone marrow is either, of the recipient has either disease or damage and is no longer functional. So what we do in a transplant is we replace the bone marrow essentially with those from a healthy donor, and we utilize a new transplanted immune system to fight whatever is resulting in this disease, and we utilize something known as a graft versus tumor effect.
Are you advancing his slides?
Next slide.
Thank you.
So when we talk about risks and benefits of transplant, we talk about, what can we, what are it's really a balancing act on how we balance and how we determine who benefits from a transplant and who needs a transplant. So invariably, we have to come to a decision, not just who can benefit from a transplant, but whether a transplant would benefit a person. So we know people who can benefit for a transplant are people with high-risk diseases that we know either are not cured by conventional therapies or have a high risk of relapse. We've heard a lot about genetic mutations today, and we know mutations that confer poor survival and may affect overall risk to prolonged overall survival. We know that certain diseases the disease does not respond to therapies that we have available. And we know that with transplant, we can achieve, in most cases, cure. Now, we have to balance these things out with the risks of transplant. And I often, when I meet a patient first time and I'm discussing transplant, I often reference this as a high risk, high reward. And I think there are considerable risks that patients do undergo when it comes to transplant. With prolonged immune suppression, they are at risk for infections, not just infections that people may exhibit in the community, but opportunistic infections that come from prolonged immune suppression. We talk about graft versus host disease, which is when we want a graft versus tumor effect, but sometimes that graft effect goes a little too far and starts attacking normal recipient organs and tissue, and can be fatal in some instances. We have to weigh how frail or how functional a patient is, because we need to know whether they have the strength to withstand the potential complications of a bone marrow transplant. A transplant is not possible without finding a suitable donor. We are fortunate and blessed to have so many volunteer donors in the National Marrow Donor Program registry, but sometimes even with that and even with related donors, we may not find the right donor, appropriate donor. And also insurance. Financial is a big component. There are lots of costs due to the complexities that are involved in a transplant. So unfortunately, there are instances where patients do not have appropriate coverage, and obtaining a transplant becomes that much more difficult. Next slide. So when we look at choosing who would be your donor, we historically still prefer a fully HLA matched sibling donor, and the complications and survival have been seen to be better with matched sibling donors. Now, as years have gone by, and with newer techniques in high resolution testing, we're able to now to get more idea about more detail about matching donors. So historically, unrelated donor transplants over time, the outcomes have improved. So so even if you don't have a matched sibling donor, a fully matched unrelated donor is still an appropriate option. Now, where things have really advanced in the past few years is about people who do not have a fully matched donor. And now, as you can see in the chart, we see that not only more unrelated donors are being used, but now more related donors who may not be full match. So donor transplants we call haploidentical transplants, which means more first degree relatives who are not a full match can be considered as a potential donor, thanks to newer techniques in graft versus host disease prevention. Next slide. So when we talk about a transplant, you may hear things like myeloablative and reduced intensity, and this is part of the conditioning or the chemotherapy that we give as a preparation for the transplant. We typically give these for about 5 to 6 days immediately preceding the donor stem cell infusion. Now, myeloablative, the differences between the two is myeloablative is much stronger in intensity, and we use these in younger patients because we think they can withstand toxicities in order to get longer durable remissions and cures. Complications for this is that we do see more graft versus host disease, more toxicities, but we see less relapse. However, when we talk about older adults receiving a transplant, they oftentimes would not be able to handle such an intense conditioning. So we use something called reduced intensity conditioning. So we use these for older adults going for transplant. We also use reduced intensity preferentially for certain diseases where we know we can achieve the same response regardless of the intensity. And one example being non-Hodgkin lymphoma, where we predominantly do use, where majority of the transplants we use reduced intensity conditioning. Next slide. So for the process of the transplant, so we start from even before this, but from the point of the being ready and having your donor and going into the transplant, we admit to the hospital, you undergo conditioning, which again was about 5 to 6 days worth of chemotherapy, maybe a rest day. Some people do require some radiation as part of their preparatory regimen. The stem cells are infused, and we start immune suppressing medications at or around the time of infusion, and we then monitor very closely in the hospital until the bone marrow and the counts start to recover, and the bone marrow has sufficiently engrafted. So most programs, this occurs with an inpatient hospitalization. Some programs, such as Rochester, have a long established outpatient program where we're able to monitor these toxicities without necessarily requiring admission. We then at recovery, they discharge a patient from the hospital, but that's not enough. We do have to watch them very closely in our clinic, because the first 100 days is the most critical period of a transplant, and it is the period where we see the most risk of early mortality. So we know keeping our allo transplant patients close to us is very important. Next slide. So when we ask our patients to stay close by, we know we are uprooting them from their life. We see patients that come from long distances or from in our own catchment area. So, how do we allow our patients to be able to reside here? So we have Hope Lodges that are at all of our sites, which allow our patients and their caregiver to be able to stay nearby And these are all on our each of our campuses, so that we can keep our patients for hopefully a minimum of 100 days within very close proximity of the cancer center. This is in large part because they will need to be followed closely in the clinic. They may require infusions, transfusions, and periodic monitoring of their immunosuppression. Next slide. So just to give you a bit of the potential complications, we see, we talk about acute and chronic graft versus host disease. And acute graft versus host disease, we see typically occurring within the first 100 days. And chronic graft versus host disease can affect more organs and can occur at any time during the course of a transplant. We see infections, and infections will vary. Early post-transplant, we see more bacterial and fungal infections, and later in transplant course, we then expect to see more viral infections. Veno-occlusive disease is something that has become we see it far less now than maybe we used to, but still it can be a very serious disease, which can impact, which is a toxicity that primarily attacks the liver and can be rather serious and fatal in some instances. And then, when we get towards the post 100 days, we get to 6 months and 1 year. Especially at the 1 year, we start thinking about long-term complications, and this is part of a BMT survivorship, that we have discussions about late complications, whether it's cardiac, endocrine, or even the secondary cancers such as skin cancers, and very rarely secondary hematological cancers. Next slide. So we mentioned graft versus host disease, and this is the most common complication that occurs in an allogeneic stem cell transplant. And aside from relapse, this is the complication that results in the most mortality from allogeneic transplant. Severities can be, we talk about it in severity, which can be very mild and can be just observed in some instances, or it could be life-threatening and can result in mortality. We see it in two forms: acute, which occurs in the first 100 days and typically involves either the skin, the gastrointestinal tract, or the liver; and chronic graft versus host disease, which can occur typically starting from 100 days onward and can affect any organ essentially, including eyes, skin, lungs, joints. And this is something that not only could it be fatal, but it could also severely impact quality of life in patients post-transplant. So one of the things we have that as a field we have worked and strive to do is to come up with regimens and plans on how best we can prevent graft versus host disease from occurring. Next slide. So when we talk about late effects, we talk about the impact of things like graft versus host disease and other complication of transplant, and what it can do in terms of your quality of life later on. And chronic graft versus disease can be quite debilitating. In severe forms, it can cause functional impairment. It can cause permanent disability. Ocular graft versus host disease, in particular, can cause blindness, and severe lung GVHD can result in compromised lung function, that people may be oxygen dependent, and in some instances may need to be considered for a lung transplant. It affects the likelihood, the toxicity can be debilitating enough that people aren't able to go back to work. and it could all cause it can cause a significant amount of distress. Next slide. So we'll move on to speaking about aplastic anemia in general. Next slide. We've just heard from Dr. Rivera speak about aplastic anemia, so we don't need to go through this. What we know is that this is a severe immune-mediated disorder that can be quite debilitating and life-threatening depending on the degree of the pancytopenia. Next slide. And just reviewing causes, most causes we don't know, but there are known causes for aplastic anemia. Next slide. So, we've discussed supportive care, we've discussed immunosuppression therapy, but for people who are eligible and people who are functional and fit enough, and those who can, we do offer allogeneic stem cell transplantation as a curative option. Next slide. So we decide who would be suitable to proceed to transplant by a number of factors. One has to do with the disease severity. One has to do then comes the transplant specific things that we need to know. So disease is one. Then we need to know, do we have a donor? We then look at the recipient and we see essentially what their age and what their comorbid condition is. So all these things really have to fall in place in order for somebody to be considered a candidate for a bone marrow transplant. Next slide. So historically, what we would look at, the decision on how we would treat aplastic anemia really resided on whether we had an age and whether we had a fully matched sibling donor. And in those instances, we would take a patient immediately to transplant, providing that there was no significant delays in getting a donor and a recipient ready for a transplant. And if they did not have a sibling donor, they would go through immune suppression therapy and then proceed to transplant if they failed treatment. Next slide. So we've mentioned some complications broadly, but specifically in transplant for aplastic anemia, we know we have risks of graft failure, graft versus host disease, and infection. Now, underneath each of these is things that have been done that have now at least reduced those risks of occurring. So with graft failure, use of, we've improved the use of conditioning, including the use of cyclophosphamide and ATG. We have less risk of graft failure with the use of irradiated products. With graft versus host disease, we use a GVHD prevention, which is cyclophosphamide called PTCY, where we give cyclophosphamide as part of the prevention on the 3rd and the 4th day following the stem cell infusion. We know that the risk of graft versus host disease is left with bone marrow graft compared to peripheral blood. So we use bone marrow graft almost preferentially. And we know that we could get less graft versus host disease without the use of mega doses or as we use lower stem cell doses. And as as the time has gone on in transplant, we have gotten better with prophylactic strategies to prevent infections. Next slide. So the post-transplant cyclophosphamide really has been one of the major advances that has happened in bone marrow transplant. This is not something that is new. This has been, developed almost 20 years ago at Johns Hopkins, and cyclophosphamide is a very cheap drug, but yet it has been very effective in the prevention of acute and chronic graft versus host disease. So, and as we know that the use of haploidentical transplantation has significantly increased, not just in the US, but worldwide. And it's quite effective, not only for match transplants, but for half match transplants, and half haplo being lambda for half. Where this really has come in has been for minorities who have been underrepresented in the donor registry. And this allows now that rather than saying we don't have a donor, we don't have a fully matched donor, you can't get a transplant. Now more and more people are able to use first degree relatives. So a child can use a parent, and an older adult can use their child as a potential donor. So this has really been revolutionary in opening the donor pool to allow more people to benefit from a transplant. Next slide, please. So this was a trial that was conducted by Amy Dezern at Johns Hopkins as the lead for with the BMT CTN. And again, what we know is that there were patients who were not sent for transplant because they did not have a fully matched donor. So this was a single arm trial to look at reduced intensity haploidentical transplant, and again using the PTCY based approach on treating aplastic anemia patients with a haploidentical donor. Of the patients reported, more than half came from underrepresented racial ethnic groups, and we had a 1-year survival of 81%, and a fairly acceptable GVHD incidence with day 100 acute GVHD at 16%, and 1-year chronic graft-versus-host disease at 26%. Now, it's important to know that the more mismatch that you have, the higher the risk of complication. So having half of your HLA being mismatched and having a GVHD incidence of 26% is actually quite good. So now we're looking at, now comes how we can build on this. Next slide, please. So instead of the current approach, which is if we don't have a matched sibling donor, you go to immune suppression therapy. But we know that people have available haploidentical donors. So should we still follow the same approach, or should we then take patients up front instead of giving them immune suppression therapy, take them up front to a transplant with a haploidentical donor? So this was the next, how we built on the last trial. This was then investigated as a phase 2 trial for people at diagnosis who had a haploidentical donor. Next slide. So 27 patients were treated on this study, and almost 40% came from underrepresented minority, and a 1-year survival was 89%. The very low GVHD, I mean, 2-year GVHD of 4% is quite remarkable. I think the trade-off was that there were more infections. However, most of the infections were not severe. They were grade 2 or less, and most of these were viral reactivation. So I think these results are quite promising. I think it could change how we really approach newly diagnosed aplastic anemia, at least from a context of offering bone marrow transplant. Next slide. So this was, we come back to this. This is the original approach. Next slide. But, we know now that survival is improving. We know that survival for transplant in aplastic anemia has improved because we have similar outcomes now with our match related and match unrelated. We have much less rejection rates. And now we know that we can get better, we can achieve very good results, even if we do not have a fully matched donor. Next slide. So how do we decide on transplant? So now maybe we should be thinking in a different way. So we make the diagnosis, we meet with the hematology and the transplant team. We conduct a donor search, we check on the comorbidity of the patient. We now know if we have a donor available and the age and comorbidity is acceptable, then we go to transplant. And if not, then we pursue non-transplant therapy. Next slide. And I think now what we need to start thinking about is, are we ready to adopt that if we do not have a fully matched donor? Should we go straight to transplant? And I think we've seen evidence where a haploidentical donors we could be adopting this approach. There have been trials in other disease settings where post-transplant cyclophosphamide has been quite effective in the treatment of mismatch unrelated. We call haploidentical mismatch related, but there have been very strong results in mismatch unrelated. And I think that may be the next study to really take a look at, is whether we can get the similar kind of approach with transplant and maybe even upfront transplant, even with a mismatch unrelated donor. Next slide. And with that, I'd like to thank everyone, and I'm going to turn this over to Dr. Khera in Phoenix to talk about MDS. Thank you.
Thank you, Dr. Murthy, for an excellent overview of the transplant process and the role of transplant for aplastic anemia. Let's switch gears to talk a little bit about that in myelodysplastic syndrome. So some of the slides here will be a repetition of what you may have already heard from Dr. Al-Khatib and Dr. Al-Khali, but I just want to set the background again. So what is myelodysplastic syndrome and how common is it? We all know it's a group of bone marrow stem cell cancers that is defined by low blood counts, abnormal looking cells or so-called marrow dysplasia, and chromosome changes or genetic mutations. We all know that it is characterized by need for transfusions, risk of infections due to the low white count, and it can range from very low severity indolent disease to very high severity, very aggressive disease that can transform to a full-blown blood cancer or leukemia. It's uncommon before the age of 50 years. Mostly it is diagnosed in our older patients who are more than 70. And just to give you a sort of a frame of reference, number of patients living with MDS in USA is estimated to be about 60,000 to 170,000, which is still much lower than breast cancer or lung cancer, but it is definitely a severe disease for our blood cancer-related patients. Next, please. So going over just again a little bit about the risk categories, we know that, as I mentioned, it can range from very low severity, very indolent process to more aggressive. And how is that decided? That is decided based on which blood counts are low, what is the number of blasts or those abnormal looking, ugly looking cells in the bone marrow, and what type of chromosomal changes are there. And that has been the traditional way of looking at the risk stratification, based on which there have been categories defined, 5 different categories ranging from very low to very high. And on the right side, you see the graphs which show a very clear separation of how those categories impact the survival and also freedom from developing acute leukemia. Next, please. So now that we know more about the genetic mutations, efforts have been made to incorporate those mutations in these risk stratification models. And we have a new system, or a relatively new system, something called IPSSM, which incorporates these mutations. And again, the curves on the right show that the 6 categories that they have been able to define based on those mutations, very well the curves separate out based on if you are very low risk, then your overall survival is best, versus if you're high risk, then your overall survival and leukemia-free survival is worse. Next, please. So again, part of this was covered. How do we treat MDS? We use supportive care, including transfusions, growth support, growth factor support, and minimal medical interventions to help manage symptoms. We can use disease-modifying agents like the hypomethylating agents, the Vidasa and the Dacogen, but transplantation or allogeneic transplantation is the only potentially curative therapy that is available to us for now for myelodysplastic syndromes. Next, please. So how do we decide which treatment approach is the best? There's, as Dr. Murthy also mentioned, there are certain factors that are going to go into that decision-making. First of all, patient age and fitness. And again, age is just a number. Some programs like us, we do have a programmatic cut or threshold of 75 years as the highest limit for the age at which we will transplant, although that is certainly under deliberation if we need to change that, but there are programs that will transplant up to 80 years of age. Again, the more important thing is the comorbidities and the fitness of the patient, because transplant is certainly a very high risk, very complicated procedure. The risk category is important because most of our studies show that transplant is better for intermediate or high risk patients, not so much for low risk patients because of the risks that are involved with transplant. However, there may be some exceptions to that, so specifically like low-risk patients, especially if they have transfusion requirements that cannot be treated by whatever treatment they are on, they may still be considered for transplant as a potential cure. The risk of treatment has to be weighed, as again Dr. Murthy showed you. There's a balance between looking at the risks and the benefits of transplant. So that needs to go into that decision making. And finally, very important, patients' goals and wishes. If a patient is not inclined to go through a life-threatening, high-intensity procedure, there are non-transplant treatments that can be offered with certain limitations, but that is definitely something that we also try to include in our decision-making about who goes to transplant and who doesn't. Next. So let's review a little bit of literature, especially because we have some newer data about the role of allogeneic transplant for MDS. Next. So most of our MDS patients are older and Medicare beneficiaries. So the Center for Medicare and Medicaid Services, they were not too impressed with the state of studies that were available, and so they came up with this program called Coverage with Evidence Development, by which they said they would reimburse for transplants only if the patients were enrolled on an observational study to look at the effectiveness of transplant. And so the good thing is we, in transplant, have this, the support of a very broad international transplant registry, with the help of which we were able to do this observational study that included about 1,000 patients. And so this was published a couple of years back, where they compared how did the older patients with myelodysplastic syndrome do as compared to the younger patients who were 55 to 64 years. And as you would see, this study enrolled from December 2010 to 2014, and as the curve on the right shows, the outcomes were quite comparable between the young patients and the older patients. However, we still weren't satisfied because it is more a controlled trial that would be considered as a gold standard to make evidence. So for that, we came up with the idea for a clinical trial, next slide please, which was a biologic assignment trial. So here I would like you to note, normally when we say trials, we say randomized controlled trial, where a patient has a 50% chance of ending on an arm that is the treatment arm versus the standard of care or the placebo arm. However, this was a biologic assignment trial by which patients who had a donor went on to transplant, and the ones who did not have a donor continued non-transplant treatment. And this was done, again, for patients aged 50 to 75 years with advanced, which is what we consider intermediate to high-risk myelodysplastic syndrome. Next, please. So here I'd like to show you some of the clinical outcomes. The graph on the left is overall survival at 3 years, which is how many people with MDS that enrolled on this study were alive at 3 years. And if you see, the blue curve is the donor arm, where it was about 48%, versus the red curve, which is the no donor arm that did not go to transplant, and that was about 28%. So there was a statistically significant difference in the overall survival at 3 years with those who had a donor and were able to go to transplant. This here is called a forest plot, and I'm going to make you all be able to review literature better. So how this works is it looks at different factors that may impact the outcome. So here they looked at if patients were responding to the prior treatment, they look at age, they look at what category of or what risk of MDS it was. And this straight line is basically the middle. Anything on the right of the straight line is when the donor was better or getting transplant was better. And if this horizontal line is not crossing the straight line, that means it was definitely better. And so that was what we saw in this trial, that for all the patients, having a donor was better than not having a donor, and therefore made the case for going to transplant for those that were able to. If the horizontal line crosses the midline, it means that there may still be some effect, but it was not statistically significant. And so that was seen for some of the things like how people had responded to prior treatment. However, again, for all age groups, especially those above 65 years and above, there was definite advantage of having a donor and being able to go to transplant. On the right side is a curve showing leukemia-free survival, meaning as we talked about, the risk of MDS, the high risk means higher chance of developing leukemia, and so that is looked at as an endpoint. So what this one showed was that about 36% of those who had a donor went to transplant were free from leukemia at 3 years, as opposed to 20% of the no donor arm. Next, please. And as a question came up earlier about quality of life, which is definitely another important outcome, not just survival for our patients, this study also compared quality of life in patients receiving transplant versus no transplant through use of multiple instruments, and they showed that quality of life was actually quite comparable between both the groups at multiple time points. Next, please. Around the same time, the Germans were doing this study where they compared, again, they assigned transplant based on if there was availability of a donor, but what they did was they gave 4 to 6 cycles of the Vidasa chemotherapy, and then after those cycles, if somebody had a donor, then they went to transplant versus continued the Vidasa if they didn't have a donor. Next, please. Again, in this one, they showed that having a donor and being able to go to transplant was better. However, what you will see is that there was definitely an improvement when it came to event-free or leukemia-free survival that was statistically significant in those that got the transplant. The red line is the transplant and blue is the non-transplant. When it came to overall survival, the curves overlap a lot more, and the statistical significance was low, and that they said was because of the lower numbers and lower power of the study to be able to detect that difference. But the overall message of this study was still that transplant, especially in those that are able to get it, have a good donor, is better than non-transplant treatment. Again, I'm a transplanter, so I am biased, but I think that what you have to realize is that there may be some bias in these studies as well. Somebody who has a donor may have a better support system, may have a better disease for all we know. However, they did try to look at all those factors in the two groups and made sure that they were relatively equally distributed to make sure that the results were relevant. Next, please. So you may have heard earlier about this, the various mutations that cause high risk, and TP53 is one of the major ones that is associated with very high risk disease. So there was some questions and concerns raised by people is the transplant still a good idea to do for those with TP53? And so based on that previous study I mentioned from the Clinical Trials Network, they were able to actually take the blood samples from the patients enrolled on that study, do the genetic analyses, and showed this data that even if you had TP53, going to transplant still was better than no transplant. And this again, the blue curve is the transplant, the red curve is the no transplant. What they also showed was as I mentioned, there's this new risk system called IPSSM. What they showed was that transplant was better, or having a donor was better in the very high-risk IPSSM group if the P53 mutation was absent. If it was present, it was better, but it was not quite, the difference was not that significant. However, again, as a transplanter, if we have a patient with P53 who otherwise meets criteria, that's what we would go with, is getting them to transplant. Next, please. So what does it mean for a patient with myelodysplastic syndrome? The first thing that has to happen is, especially if you are seeing a regular hematologist, there has to be a referral made from the treating doctor to a transplant center, transplant doctor. And so then the transplant team will be the one to assess the candidacy for transplant. They will work with the treating doctor on developing a care plan, search for donor, etc. And once all of that is done and a best donor is selected, dates for transplant are decided. We work backwards from that date. We try to do a very comprehensive evaluation. We check out all organ systems and make sure that a person is able to safely undergo transplant before we would bring them to or admit them for it. Next, please. So what determines the success of transplants? In general, transplants are most successful if, so from a disease standpoint, if their myelodysplastic syndrome is in remission at the time of transplant. So I said it's a potential cure. It's not 100%. But what we know is if someone has very low burden or no burden of disease going into transplant, the chances of success are probably the best for them versus somebody who may still have some blasts or some genetic mutations lingering around. For aplastic anemia, some of the factors that Dr. Murthy mentioned, having a bone marrow graft, having less amounts of pre-transplant transfusions because they can increase the risks are important factors to consider. In addition, other things that have to come together are good organ function. We want people to have good liver, lung, kidney function that can allow them to go through this intensive process. They have to have an optimal functional status, meaning they should be active enough to be able to take care of themselves, even if they may not be running a marathon, but that functional status is very important as a sign of recovery from the transplant. They should not have a major uncontrolled infection because transplant means more immunosuppression, and so that can flare up the infections, and so we would like our patients not to have any uncontrolled infections before going to transplant. And finally, very, very important, good psychosocial support in terms of a caregiver, in terms of financial planning and so forth is important. Next. So what can you do to prepare for the experience and improve the chances of a successful outcome? Get information about risks and benefits of transplant. Explore non-transplant options such as clinical trials. Again, as Center of Excellence for myelodysplastic syndrome non-transplant treatment, there are Center of Excellence for transplant associated things too. And so you would have to carefully select a transplant center. Now, for some people, it may be dictated by their insurance as to a certain center, and that may or may not be something that is close to them, and that's where the Hope Lodge facility that Dr. Murthy mentioned is important for people who are relocating from their house to be at a transplant center. Continue to optimize your functional status and nutrition. This is the one thing I tell all my patients when I see them for the first consult is what you can do is make sure you eat as best as you can to develop a nutritional buffer. Make sure you stay as active as you can to be able to then move to transplant and try not to get a bad infection. Important to also select about caregivers, have a caregiver plan. Some people may not be able to have one dedicated caregiver throughout this process. It's okay to have more than one as long as there is a good plan in place. And plan your finances. Financial toxicity of transplant is very well known. And so again, making sure that things are being planned for. And again, we have a session on holistic care where we have our social worker and navigator talk about some of these difficult things, but that is an important aspect of a successful transplant as well. Next, please. I see some caregivers here, and you guys are very, very important in this whole process. What can you do as potential transplant caregivers? There can be three main areas of support. Medical, obviously. The patient themselves might feel very tired, not really able to understand or comprehend. So from a medical standpoint, as a caregiver, we would hope that you are able to gather information, talk to the doctors, ask questions, and help care for the patient. Help with the financial aspects. There may be times when you have to call the insurance company to find out about authorizations and so forth, and help manage costs and daily finances. And most importantly, the emotional and social support is very, very important. And we have some studies going on that are looking at that aspect of how can caregivers and patients interact better in terms of providing each other support. But what is also very, very important to realize is taking care of yourself while caring for your loved one is important, and there are resources, so feel free to reach out if you have questions about what resources you can leverage for your own care while you're taking care of your patient. Next, please. So to conclude, allogeneic transplant is curative, both for myelodysplastic syndrome and aplastic anemia. Who is a candidate? Patients with high-risk MDS or severe aplastic anemia who have an available donor. And as we discussed, in this day and age, really not having a donor is probably not a problem for anyone. Our patients do have to be medically fit with good performance status and limited or at least managed comorbidities. So this is what we really hope, and this is where Lee and AAMDS Foundation has been really helpful to us, is encourage the hematologists to refer to the transplant center early in the course of disease so that you can be evaluated and optimized if you do need to go to transplant. But we do consider transplant only when we feel the disease is under best possible control and the patient is otherwise fit as determined by the transplant team. And in terms of how, it's a complicated multi-step process involving a lot of different team players, but most transplant centers work together very closely within their center and with the outside doctors to be able to provide care for patients who do need to go through this process. With that, I think I will end and happy to take any questions.
Thank you so much, Dr. Khera and Dr. Murthy. We'll start in Phoenix. Were there any questions in the room here at the moment? Okay, great. Do we have any questions in Jacksonville?
No, we don't have any questions in Jacksonville.
Thank you. Rochester? Rochester, any questions?
I think we have one question here in Jacksonville, actually.
Okay, thanks, Dr. Murthy. We'll go to Jacksonville.
Thank you. I know you mentioned in being considered for a transplant that good organ function was one of the things you mentioned. If there is a issue with the kidneys, but it's not severe, I know the nephrology might say she's cleared as far as I'm concerned for things. Would that still be okay to go ahead with transplant? Would you need clearance like from nephrology or clearance from a different doctor for transplant? Is that how you would handle that, or who would make that decision?
Hemant, I can go and then maybe you can chime in. So I think that's a great question. As I mentioned, limited comorbidities or comorbidities that are managed appropriately. So yes, if our nephrologist, we usually will want you to be seen at our center by our specialists, but if our specialist was able to clear you and say, okay, we'll need to follow you carefully, but you are cleared for transplant, then that should not be a contraindication to transplant. But what we do have to realize is that the risks increase every time we have some problem. However, our specialists also realize that what you have is a life-threatening disorder, and so that's where they carefully weigh the risks and benefits of moving forward with transplant versus, not doing it if the organ function is really compromised.
Okay, thank you.
Sure, and I can add a little to that as well. So we did actually publish data from our international registry that particularly looked at kidney function and the degree of dysfunction and outcomes. And you can have mild dysfunction and the survival was not severely impacted, but severe dysfunction, dialysis, that compromised significantly outcomes in allo transplant patients. We typically, different type of transplant, but autologous transplant, we transplant people even who are requiring dialysis. But allo transplant, I think it becomes, when it's very severe, we probably will have maybe more pause. The other thing also with knowing about the kidney function is that sometimes it may change. We may adjust the transplant plan if we know there's some kidney dysfunction. Maybe we may try to stay away from things that may be nephrotoxic and come up with a different plan. But I think the degree of the kidney dysfunction is quite important.
Thank you very much. We do have some questions online. Our first question is, do you have to have severe aplastic anemia for transplant?
So I think it's a good question. And I think what I would say is the reason we would say severe aplastic anemia is not because the aplastic anemia would not be considered curative with a bone marrow transplant. But as we've discussed, there are a lot of significant risks that come with a bone marrow transplant. So I think it's a matter of weighing out the benefit and the risk. So if you don't have severe aplastic anemia, maybe we don't need to put you through a transplant. But if it becomes severe enough where the cytopenias are becoming life-threatening, where they are severely impacting quality of life, and then I think then it becomes a factor of this, then we can pursue the curative option where the benefit would outweigh the risk. So and that's even in MDS, and I'll let Dr. Khera speak to that, but oftentimes transplanters, we have to weigh what is the risk of the disease and whether the risks of a transplant really are enough that we should put someone through this. It is a high risk, high reward. So we really need to make sure we're doing right by you.
Yeah, I would agree. In fact, when I talk to my patients, I tell them that we would go to transplant only if we feel that the benefit we can give you is in the range of 25 to 30% or higher. If the benefit is only about 5% or so, going through a process that has by itself a chance of mortality of 10 to 15% sometimes is not worth it. So it is a nuanced decision, and we all try to make it weighing in the patient's wishes and discuss it with our group to be able to get an opinion on moving forward with the transplant for a patient or not. So,
thank you for that. We have another question online. The question is, if you have an overlapping disease, such as aplastic anemia and PNH, if you have a transplant, are both diseases cured? And then after transplant, do you have a risk of developing another illness?
So I guess the simple answer is yes, you can cure because both diseases have a transplant indication and both can be cured with a bone marrow transplant. So yes, both diseases can be cured. And we've seen this even in other hematological diseases, if there are two concurrent diseases, one transplant can potentially be curative for both processes. The second question,
Risk for secondary cancer.
Risk, thank you, Dr. Khera. It was, once you've had a transplant, are you at risk for developing any other bone marrow failure diseases?
yeah, you can take, I think you can take this one.
Yes, secondary cancers are usually a late effect that we do worry about in our transplant patients. They can be blood-related cancers, they can be solid cancers, skin cancers, but in general, yes, we do worry about secondary MDSs and secondary leukemias as the late sort of effect or late sequela of transplant for our patients undergoing this. And it may not be just the transplant, it may be all the treatment that you've gotten before that sort of combines together with the cumulative effect of that.
And we have one last question before we end. Is there a future for CAR T cell therapy for aplastic anemia or MDS?
Aplastic anemia, I think, is difficult. So, one of the principles of CAR T therapy is having a target, and I think that has been, has been easier in developing a targeted approach for certain diseases like non-Hodgkin lymphoma and myeloma, and even acute lymphoblastic leukemia. They share a target that you can then engineer onto the T cell and direct the therapy. So in aplastic anemia, it's probably difficult because I think you just really need more of an immune-based approach. But in MDS, AML, those are being investigated right now. We do have early phase trials that are looking at this. It is definitely further behind than some of the other heme malignancies because of certain things where finding an appropriate target is harder with leukemias per se, because not only are you trying to find the appropriate target, but because the disease is a marrow base, we also have to worry whether this will cause irreversible damage to the bone marrow. So that's why right now this is still in very early phase 1. We're also looking at whether other types of immune cells with CAR technology are effective, such as natural killer cell. So I know, so one of the trials we do have here for CAR NK, and I know they do have. I know CAR T is in other Mayo sites as clinical trial for AML, and some of the trials will allow MDS for high risk, but it's still very early, but more to come in this space.
Dr. Khera, anything to add or?
No, I think he covered it very nicely.
Thank you very much. Well, thank you so much, Drs. Khera and Dr. Murthy, for sharing your time and your expertise with all of us. This session will be available later today on the conference platform and will also be available on our website within just the next few weeks if you'd like to rewatch again. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org. Give us a call at 800-747-2820. And I'd like to say goodbye to everyone in Jacksonville and Rochester. Thank you so much for spending your Saturday with us. We hope you found the conference helpful and that you enjoyed being able to connect in person with other patients and families. We wish you all safe travels home, and to thank you to our medical chairs in Rochester and Jacksonville. This conference was amazing today and one of a kind to be able to bring everybody together. So thank you so much for participating and working with us. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family as we've done for the past 40 years. This concludes the session.